Dr. Hina, Dr. Minam Akbar, are you there? Please identify yourself. Or any one more random candidate can present with me. Who wants to present? Just say a hi or a hello to me in chat box, please. I just unmuted for safety issues. You can just still communicate with me in the chat box, whatever doubts you have. Any doubts, whoever have can communicate. Who wants to present? Why everybody is dead silent? Anybody wants to present, please come up, come forward and say a hi or a hello. I am ready to unmute you. Hi, Dr. Emika. Okay. Dr. Only one person, Dr. Emika just said hi. I'll just unmute her. Can you hear me, Dr. Emika?
I
Hello?
can hear you.
You can
I
hear?
can hear you. Yes,
Oh,
I can.
okay, that's perfect. From where you're from, Doctor?
I'm from England.
England.
Yeah.
Okay, that's great. So you will do the first case with me, okay? All right.
All right.
Yeah. All right. After a long time, we are just starting our sessions, free sessions from Pacesdiaries, and this is completely going to be free session, and it's going to be Paces oriented, but a lot of other internal medicine stuff will predominate from this point of time because of my association with Society of Bedside Medicine, and we are going to see some approach to dysphagia, some clinical scenarios which have come recently, some communication scenario, and we're going to have a quiz on dysphagia and some differential diagnosis and approach. Okay, it's going to be an exciting session. We are going to just sit and learn together. After a long time, we started here, and I'm really happy about that. We welcome you all from the team, and I'm Dr. MJ Wesley. I hope all of you know that. And I'm now working along with Society of Bedside Medicine. I'm an accredited medical educator, and I'm now with BAPIO Training Academy, PG Med UK. All right, I'm also the co-founder of Pacesdiaries. Okay, with no further delay, this is the first case of dysphagia. We are going to discuss Dr. Uh,
You can call me Henry.
yeah, Henry. Okay, all right,
Yeah.
Doctor. Yeah. Please go ahead and take 5 minutes, and I give you 5 minutes. Once 5 minutes is done, you're going to start the case. All right. 5 minutes preparation time. And remember, any clinical consultation, just divide this in this format: 8 plus 5 plus 2. 8 minutes is for history taking. I'll give a warning at 8 minutes, which is not typically going to be given in your examination, and 5 minutes for examination of the patient. And when the last 2 minute warning is going to come, you're going to concentrate on addressing concerns. That's it. Thank you, everyone. Thank you, Dr. Vikash. Thank you, Dr. Yeah, thank you, Dr. Mozam and Dr. Raha. Yes, I'm in good health. Of course, thank you so much. I'm still in my late 30s, still good health. Thank you so much, Doctor. Like, pleasure to see you all. Pleasure to back here for teaching. All right. Clinical medicine is what we are trying to do. Only thing, whatever we are trying to do with bedside medicine now in the era of AI, if we have a bedside medicine conference in US, like anybody, wherever you go and tell bedside medicine, nobody is even minding that much because now everything is advanced. Still, paces holding on to the bedside medicine. which is needed much in this era. We are just trying to find a common line between the advanced medicine, the bedside medicine, somewhere common where we can actually interact with patient and keep the bedside medicine alive. Other people are here. Dr. Hina and Dr. Meena Akbar. Meena Akbar, are you here? Please, back to back, we have to do cases before we going to start discussing theory part, and we are going to start discussing differential diagnosis and how to approach dysphagia. Are you both here? Yes, Dr. Meena Magmar and Dr. Hina. Yes, you are here. Next is Dr. Hina. Be ready. That's your another clinical consultation case. That's for you. And this next followed by the Dr. Meena Magbar, your case. We have 1 minute 30 seconds left for Dr. Henry. 30 seconds more, Dr. Henry. Just be ready. I'll just start.
Okay.
Yes, doctor, your time's up. Can you start? I'll stop you at 8 minutes of history taking. Okay.
Good morning. I'm Dr. Henry. May I confirm if you are Miss Lela, 48 years old?
Yes, doctor. I'm Layla. I'm 48-year-old female doctor. Yes.
Yeah. Pleased to meet you. I'm here to take some few history from you to ensure that whatever we are discussing today will be kept confidential. If you don't mind, can we proceed?
Yes, yes, please, doctor. I'm waiting for
Okay.
doctor to come and help
All
me.
right.
Go ahead. Yeah.
All right. I received a letter from your GP saying that you have some difficulty in swallowing. Can you tell me more about it?
Yes, doctor. Like I have difficulty in swallowing, doctor. I'm just like, trying to keep down the food or water. Just like, it's getting very difficult for me to swallow, doctor. Like it's just like I'm suffocating. I'm just suffering a lot. I'm not able to eat as a result of that. Nearly, I'm scared of touching any food or even water.
Oh, that must be very difficult for you. I'm so sorry to hear that, but not to worry. We'll try our best to address that. Is that okay?
Yeah, that's perfectly fine, doctor. Thank you so much. That's so kind of you.
All right. If I may ask, sorry, did difficulty in swallowing? How did it start? Is it from with food or with water? Can you tell me which of them started first?
Yes, doctor. I don't know. Maybe like food, I would say. And I just started noticing it over the last 1 year. I thought it's something like to do with my, maybe some indigestion or something like that. And at first, I went to a GP. He just checked, and then I went to an ENT surgeon. He just checked whether some tonsils are grown or something like that. And they told nothing is wrong. You're fine. And then again and again, I started noticing gradually now, like I'm not able to swallow.
I'm so sorry about that. If for how long now, if I may ask?
Doctor, now it has touched now nearly, doctor, it's been around 8 to 10 months now. I'm not able to keep the food down.
Okay, and I guess it has been progressing, right? It has been worsening. Is that
Yeah,
not?
it is worsening, doctor. You're right. Absolutely, it is worsening.
Okay. Do you notice that you whenever you taking something, you feel as if you have pain in your food pipe? Do you feel pain when you swallow?
No, no, I don't have a pain in my food pipe, doctor. It's just like the food
Okay.
I'm not able to swallow down. That is the problem. I don't have a,
Okay.
I'm not able to
Understand.
swallow down.
Okay.
Yeah, exactly.
Okay.
I'm not able to swallow down the food. Yeah.
Okay. Do you have any dryness of the? Do you feel as if your mouth is looking dry?
No, absolutely not, doctor. My mouth is not dry. It's absolutely fine.
Okay. Okay. And you don't feel as if the food is sticking in your gut, in your windpipe, right? Do
No,
you feel it sticking in your wind?
no, it's not sticking, doctor. It's just like, I don't know. Once I put the food in the mouth, it's fine. The moment the food goes from the mouth to the throat, it is slowing down. It is like kind of like choked up. It just like stuck. And then it takes a long time for the food to go down.
Okay. What of water too? Do you experience similar thing with taking water?
Yes, yes, of course. Even with the water as well, doctor.
Okay. So sorry. Have you experienced any weight loss?
I'm these days like maybe 3, 4 kgs I would have been down, doctor, because I'm not eating anything at all because of this trouble. I'm really afraid and scared to
Oh,
eat new food.
I can imagine. Do you have any loose stool? Have you having loose stool?
Loose stools per se, I have maybe like once or twice I had, doctor, but not often.
Okay. What of constipation? In terms of, does it take you time to go to the loo?
Mm,
Your number two, kind of.
I don't have a constipation or anything, doctor. Sometimes I just feel my
Oh,
stomach
okay.
loose. That's it.
Oh, okay. Have you experienced any vomiting
No, no, doctor.
of throwing up? Do you throw up? Do you throw up?
No, no.
Sorry.
I don't throw up, doctor. I don't
Okay.
throw up at all. Okay.
Okay. Any neck swelling?
Some swelling is there in the neck, doctor. I don't understand. Like, I just went to the doctor. He said it could be some thyroid and he just gave me some appointment. And I don't know. I have some swelling in my neck.
Okay. Can I see the neck if you don't mind?
Yeah, yeah, you can see my neck, doctor. This is my neck.
Okay. All right. All right. Thank you for showing me. And do you notice that it's the swelling there is going gradual? Has it been going or it has become constant ever since?
Yes, doctor. The swelling is now gradually going up. That's what I'm noticing. Like in the last 8 to 10 months, I just like initially I saw it was small. Now it's growing big, big. And I thought like why I would take medicine. I just left it like that because I don't trust Western medicine. So, but now it's just enlarged.
Okay. Do you feel pain if someone touch the swelling? Do you feel pain on it? Is
I'm
it
sorry.
painful?
It's not painful, but it is kind of giving some discomfort in my throat.
Okay, okay. If I'm asked, sorry, do you usually when people are complaining that they are feeling cold in winter, you also complain you are feeling cold also?
No, no, I don't feel cold in the winter, doctor.
Okay. What do you can you tolerate summer period, maybe hot
Summer
period?
is a little difficult for me, doctor. Summer period is a little difficult for me. I just like, start getting sweaty a lot.
Okay. If I ask, do you have any headache?
No.
Okay. Have you feel as if probably you are losing your hair?
No, my hairs maybe a little bit, my hair strands are falling. I noted down these days when I'm just taking shower, like, my hair strands are coming down. Strands of
Okay.
hair.
What of your eyes? Any blurring of vision?
No,
No blurring of vision. Do you feel as if your eyes are feeling gritty?
no,
Any bulging of your eye? Do you feel as if probably your eyes are bulging?
no, my eyes are not at bulging.
Okay. Do you drive from sorry?
Yes, of course I do drive vehicle, doctor. I drove and
Okay. Okay. It doesn't. You haven't noticed any difficulty while driving, right?
oh, I was driving fine. I just came driving fine. I just came normally.
Okay.
Yeah.
All right. If I may ask, sorry, do you have any tingling sensation in your hands, like pins and needles?
Where, doctor?
You do have it, right?
No, I mean, like where? Pins and needles. I don't
Yeah.
have where.
Okay, you don't have it. Okay. Have you probably had any rash in your skin? Any skin rash?
No, not at all, doctor. I don't have any skin
Okay.
at all.
Okay. Any difficulty in standing from sitting position or combing your hair?
No, I can comb my hair. And sometimes if
You,
I stand and sit, that time I feel little weak.
okay. Okay. And what of the reason of your heart? Do you feel any reason of your heart?
Sometimes my heart races, doctor, without any doubt. For a long time, it just
Oh,
like
so,
it just goes fast. No,
I'm so sorry about that. Do you feel as if you have any cough? Do you cough?
no, I don't have a cough.
Okay. Any shortness of breath?
Sometimes I feel shortness of breath.
Okay. All right. Do you have any um, history of, previous history of hospitalization or any condition you have been managing in the past?
Like what conditions, doctor?
Let's say like skin condition, maybe like excessive diarrhea or loose stool, or probably hypertension or diabetes, any of them?
None of those, doctor. I don't think I have any of those conditions.
Okay. What of any family history of similar condition?
Family history, I don't remember, doctor, anybody having this kind of condition. I think I'm the first person to take this.
Okay. All right. Have you had any surgery previously?
Oh, only one surgery I had, doctor, during 8 minutes over, doctor. You're 8 minutes over. You're taking history.
Okay.
Remember, eight
All
minutes.
right.
Okay. You
Okay.
one
Okay.
surgery I
I
had,
am.
that is during my childbirth. I just had this lower segmental cesarean section.
Okay. Do you mind if I examine you while continuing the discussion, if you don't mind?
Yeah, yes, doctor. You can do
Okay.
that. What do you
Okay.
want, doctor?
Okay. Yeah, I want you to be seated. Let me look at you from a distance. I'll be giving you this cup to hold. First of all, can you open your mouth for me and protrude your tongue?
Yes, she can put out the tongue.
Okay. Okay. I can look at the neck. Okay. Good. Okay. Does it move with so, protrusion of the tongue? No. The
It doesn't
swelling on the neck.
when she protrude her tongue. Okay, 9 minutes.
Okay.
Yeah.
I give you the water, put in your mouth, but don't swallow it, please, if you don't mind. Okay. I want you to swallow it now as I look at your tongue. As you swallow it, any changes? Does it move with swallowing?
Yes, the swelling, if she swallows, it just moves.
Okay. 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 Before I go behind you, can you just stretch your hand? Let me see. Stretch up your hand. Okay. Put your paper on the hands and see any fine tremor.
Some fine tremor is there, doctor.
Okay. Then check for any tracheobronchopathy, anything like look like finger clubbing in the
No,
hands.
no.
Okay. Look at the pulse and palpate the pulse. What's the pulse rate? Is it regular? The pulse.
Pulse is regular, just tachycardia, nothing else.
Okay. Then do you mind? I want to take permission for the BP. What's BP like? Sorry, the BP.
It's the same blood pressure, whatever as
Okay.
mentioned outside.
Okay. Standing and seated. Okay.
Yes,
Then
yes.
go to
Natural change.
behind her. I go to behind. I'm going to behind you now, please. I'm touching your neck. I want you to, take this water in your mouth and swallow it as I touch your neck. Okay.
Yes, you can
Swallow
check.
it as I touch.
You can,
Okay. Then I touch the neck as she swallows, and also as she protrudes her tongue. Then I palpate the neck and check for try to look at the size of the thyroid gland, if it
it's
is regular, if it is diffuse.
formally
Then
enlarged
okay,
both sides.
okay. Then I examine for lymph nodes around the neck. Then check percus retrosternal extension, percus and see there is retrosternal extension.
Okay.
Then after doing that, I use my stethoscope to auscultate each of the glands and see if
Yes.
there's any bruit.
Yes, doctor.
Or if there's any
You have 30 seconds left for examination.
Okay. All right. Then after can you just look at me with your eyes? Do lead lag and lead retraction, and then
No,
hemiplegia. Anything?
nothing is there. No lid retraction.
Okay. Can you just fold your hands and stand up from sitting position?
What do you want to do?
Prosmal myopathy. Stand up. Cross your hand and stand up from sitting position.
Yes, she can.
Anything? Okay. Then I strike ankle reflex. Take ankle reflex. If there's delay response.
2 minutes left.
Okay. Do you have any concern? Do you have any concern?
What is happening to me?
And looking at what I've seen so far, I'm of the opinion that you're having what they call Graves' disease,
Okay.
and that is what is causing your difficulty in swallowing. It's a condition whereby there is a problem with your immune defense. that tends to affect your gland in your neck. That's why you're having similar problem.
Okay.
I will do it to address that and we do it a whole of test, then address that for you. Any other concern?
And doctor, is it curable?
Actually, it usually as it is now with some medication and such surgery or surgical procedure, we may tend to control it for a long time, and after certain duration, we'll put you under monitoring, and then from there we can see if it will, be treated or not. But at this time, I think we'll try our best to ensure that we can treat your
Okay.
condition.
Will my children
And
get
please
affected?
some long-term medication.
Will my children will get affected because of this?
I can't say categorically, but your children has higher risk compared to other children, other population from having similar condition.
Okay. All right.
Okay. At this point, I want to also counsel in terms of at this point, you may need to stop driving for now, so I can be able to do some other. Why would do some tests and see if your vision is affected.
Okay, doctor.
And also, if it been affecting your family life, your lifestyle.
Yes,
Do you
yes.
smoke?
Time's up, doctor. Your time's
Okay,
up.
you may need to.
Yeah.
Okay. All right.
Your time's up with the patient.
Okay.
Can you please tell me your positive physical signs you found here? Just the physical signs.
Okay. On examination of my patient, of Mrs. Lela, is observed that there's is tachycardic with fine tremor, is observed fine tremor tachycardic with a diffuse neck mass, which I observed to be a thyroid mass, because it's protrude with it moves with the swallowing, but not with protrusion of the neck, and there's obvious retrocessional extension and possible and trills, but I have an only lag and lead retraction. With looking at my patient generally, want to attend a provisional diagnosis of diffuse multinodular goiter likely due to Graves' disease.
Great.
Differential diagnosis of
Can you
Graves'
give
disease.
three causes? Can you give me three causes why she's having dysphagia?
Because the excess growth of the compression of the windpipe, compression of the esophagus by the mass compression. Then it could also be to the autonomic manifestation of the Graves' disease also can be a cause too.
Autonomic.
And basically may also be autonomic due to autonomic manifestation of this condition, and maybe due to compression of the compression effect of the gland to the windpipe, which is the esophagus, and then maybe also due to the problem with salivary gland production that might affect swallowing.
That is quite rare.
Yeah.
That is more common in Sjogren's syndrome. Okay, can you tell me the specific investigation which you are going to do for this particular lady?
At this point, I would like to order for thyroid function tests,
Okay,
T3, T4, and TSH, and also order for the thyroid antibody test and radioactive, thyroid antibody test.
Okay.
Basically, with radioactive uptake scintigraphy in the patient.
Okay.
Hello.
Yes, doctor, I can hear you. Okay, so how are you going to manage this lady? This lady is there, for example, in A&E. You are the medical registrar. You are the endocrine registrar. You have been called. What management plan you're going to give for them? Hello, doctor. Can you hear me? Doctor, can you hear me? Hello, doctor. Can you hear me? Dr. Henry, can you hear me? Can others hear me? Can others hear me? Can someone type in the chat box or anything? Yes, you can hear me. I don't know what happened to him. Okay, you're muted. Okay, fine. I'm, yeah. Wait. I'll just unmute you. Okay, I'm really sorry. I'm just unmute you. Yes, doctor. I told you to unmute. Okay.
All right. All
Yeah.
right. Thank you very much. So can you repeat your question again? I didn't get it. Sorry.
Yeah. How are you going to manage? What is your management plan for this lady as an endocrine registrar or a medical registrar?
Okay. At this point, I'm going to counsel the patients of the disease condition and the line of manage. Then my patient will be from multidisciplinary team, including the endocrinology, occupational therapy, and diabetes, endocrine nurses, specialized nurses,
Okay.
and also being at the fact that it's having enlarged mass, counseling on the need for surgical intervention, first of all, and then since having tachycardia, we may commence symptomatic management replacement propranolol, and then starting on carbimazole, carbimazole, either via the um, block and replacement or the titration method. Eventually, if once my patient becomes euthyroid, we'll this counseling for surgical management. Then advice for smoking cessation, and also
All right. Okay. I'll stop here.
yeah, basically.
Yeah, I'll just stop here. Couple of things I'll tell you what you've done right and what you've done wrong. Your clinical knowledge is good. You just went ahead and you just gave a differential diagnosis. That's fine, fair enough. But coming to your clinical communication, if you're going to take a history up to 9 minutes, that can go wrong against you. There are a couple of things that went completely missing in personal history. Not there. Triple P, we call. What is that? Periods, pills, pregnancy.
Pills, yeah, pregnancy, yeah,
Not
it's
there.
true.
And again, the social history, what she's doing for a living, how this is exactly impacting her day-to-day life, it's not there. I'm sorry about the pen. It is writing very light because of some software update in my MacBook Pro. Okay. So if these three headings are not at all there, then history taking certainly it will go unsatisfactory. One, two components, it's fine. Maybe you didn't ask about recreational drugs, they'll be fine. Maybe you didn't ask about her casual partner history, they'll be fine. But smoking, alcohol, periods, pills, pregnancy, social history, nothing is there. That will straight away send you there. Coming to your welfare, it's fine. At the end, you asked about driving and everything. You had addressed the concerns, that is fine. Your way of addressing and a management plan, that is fine. And what are the differential diagnoses you told is goiter is enlarging and compressing the foot pipe, you should tell. You kept on telling windpipe. It's not a windpipe, it's the foot pipe. When the windpipe is compressed, voice change will be there.
Sorry.
And there will be strider will be there.
Yeah,
Foot pipe is compressed, that's going to be difficult to swallow. Then again, you told about dryness and autonomic neuropathy. The second differential diagnosis here is going to be little surprising, I will tell you. The first cause here is obviously the goiter is going and compressing. The second cause here is going to be thyrotoxic myopathy. What is thyrotoxic myopathy? Thyroid hormone excess can cause myopathy. Thyroid hormone decrease can cause myopathy. So this thyrotoxic myopathy is something that will cause weakness of muscles, not just your proximal and distal muscles. It is going to cause weakness of the muscles that are responsible for your swallowing, that is your pharynx and esophagus. That is a second differential diagnosis. Third, you can tell anything. Dryness due to autonomic nervous system disturbance in thyroid. Down the line, it can be. You can give a differential diagnosis why the goiter could be. It can be a Graves. It can be some malignancy also, because over the time of 8 months, this swelling was there in this lady. So differential diagnosis, these are the differential diagnosis. Goiter is one, that's a very open diagnosis. Oh, that's a swelling that is compressing. But you have to give the sub-differentials. What is the cause? Otherwise, this will go borderline. Your examinations are fine, but still you don't have time. You don't have to do this ankle reflex and all. That is for hypothyroidism. Here you have to check for pretibial myxedema. Here you have to check for other thyrotoxic change. Any voice change is there. Okay, but still, you will be safe here. This is the column that can get you into trouble. Differential diagnosis, you will be definitely working on. But history taking, just always, my dear doctor, just keep 8 minutes and practice. No more history taking beyond 8 minutes. If you do it properly, 8 minutes is more than enough. You don't need anything beyond 8 minutes. The differential diagnosis here are the goiter and subdifferentials of goiter and thyrotoxic myopathy. Then comes thyroid autonomic neuropathy, dry mouth, whatever it is you can tell. Without telling this to other things, if you tell, they will not be happy. And there is another sign here. Can anyone tell me what sign is this? See her face when her hands are raised. What is the sign called? See her face when her hands are raised.
It start with D. Pemberton sign.
Yes, this is called
Pemberton sign.
This is due to the retrosternal extension. If you just ask the patient to lift the hand up, there will be flush in the face. So these things you can ask in the history. Then you can ask anything, any issues with your voice. Have you noticed any change in your voice? Hair fall, you had rightly asked. And then you can ask any, I said about difficulty in breathing. And the thyroid history went up to 3 minutes. It shouldn't go up to 3 minutes. Okay, it shouldn't go up to 3-4 minutes. Specific history is only 2 minutes. Just you should put the bullet point and then go for systems review. Systems review, because it will reveal a lot of things. Okay, systems review will reveal a lot of things. You can see the Pemberton sign again. The differential diagnosis are goiter and subdifferentials with thyrotoxic myopathy. Thyrotoxic myopathy affects the oral and pharyngeal muscles. That's very, very important. So this is the case. It's a very straightforward case. There is nothing much here. Just straightforward. You can go ahead and address and finish it. Okay. Any doubts, anyone? Just ask me before I unmute the next candidate, Dr. Hina Vimal. Okay, are you there, Dr. Hina? Where you are? I just have to find your name here. Dr. Hina, can you just say hi from your ID so that I can figure your ID? Yes, you are here. Okay, fine. I'll just find your ID. Dr. Hina, where you are. Yeah. Yes, doctor, you can unmute yourself. I'll get your case here.
Hello, sir.
Yeah, hello, doctor. How are you doing? It's been a long time.
Yes, I am fine. How are you?
Yeah, I'm okay, doctor. Thank you. This is your case. This is a recent case that came very recently. Okay, we got a similar patient. This patient was, I hope a lot of people would have seen my status. This patient was featured in my article in Society of Bedside Medicine in Stanford, Mount Sinai Hospital, USA. This patient case we have posted. The same patient we got. It's a recent case for Paces. I just got a similar looking patient. Okay, you take your 5 minutes and prepare. We will start.
All right, sir.
Yeah, chart, leave the chart. Chart has nothing. Once you go to the case, a lot of things will unfold. All the mysteries will unfold once you go into the case. Okay. Prepare 5 minutes. We'll start. No, doctor, you can do Pemberton sign as long as the patient is not going to faint, but it's not needed. I don't include Pemberton in thyroid sequence. If you see in our website, we don't include in Pacesdiaries the thyroid sequence. We don't include Pemberton sign. We never included that. But you can see whenever you are in a doubt whether you should do a sign or not. If I can tell something, other mentor can tell something. There is all respect to every mentor. The best thing to do is turn to the examiner and ask, sir, can I do the Pemberton sign here? They will tell yes or no. During my last examination, which I passed, what has happened is I had a doubt because the guy had a clean gynecomastia. Gynecomastia can be actually painful when you palpate if you see gynecomastia. Many people thinking the pseudo gynecomastia is gynecomastia. No, that is not. All when people get fat, I'm not mocking anyone. When people get fat, our breast tissue, like chest tissue, the pectoral fat tissue will come up. That is pseudo gynecomastia. Real gynecomastia is different. If you carefully see, not the entire pectoral muscle will, this pectoral fat tissue will come out. Only a part of it, the glandular part alone will enlarge. Like that, I had a patient who had a clear glandular part enlarged. I just turned and asked the examiner. David Black sir was there, like he was a former president RCP. He was there, and he was like, "Okay, examine." Then I went and examined. He allowed. So sometimes they allow. Sometimes they will tell not needed. Sometimes some patients may have an unrelated scar that is not related to that case at all. So that time they themselves will prompt and they will tell you just ignore the scar. Ignore the scar means completely ignore. You don't sit and just think in your head like this scar could be that, this scar could be related to this symptoms. Just talk to the examiners. They are there to help you. Just turn and talk to them. They will help you. Nobody is your enemy and nobody is coming there to fail you or destroy you or anything. Just turn to them and talk whatever doubt. This is what repeatedly I used to tell. Whenever you have a doubt, it doesn't matter. I told something, any mentor told something, or what you read in a book or seen in a video, whichever video that is, just talk to the examiner, and the examiner will be able to tell you whether what you have to is right or wrong. Okay. Okay, doctor, your time's up, Dr. Hina. Are you ready?
Yes, sir, I'm ready.
Yeah, just a second. Yeah, go ahead, doctor.
Good evening.
Yes, good evening.
I'm Dr. Hira, one of the doctors in the clinic today. May I confirm your name and age, please?
I'm Sheila, doctor. I'm 70 years old.
All right. So, Ms. Sheila, we are here to discuss regarding your health condition. Later, I'll be examining you, address your concerns. Is that all right with you?
That's perfectly all right, doctor. Please go ahead.
So, I've gathered from the notes here you're having some difficulty in solving. Is that right?
Yes, doctor, I have difficulty in swallowing. It's like getting worse.
Mm-hmm. All right. So, this must be very difficult for you. I will try to sort it out and help you accordingly.
Thank you so much, doctor. That is so kind of you.
So before I discuss this in detail, may I know your background medical history? Do you have any diagnosed medical conditions that I should be aware of?
No, 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 doctor. I'm just poor old lady from village. I don't know anything. I'm just living my life. Hardly I have some joint pains or tiredness. I just go and get some multivitamin and eat and live.
All right, all right. So, Mrs. Sheila, coming back to your main complaint, can you please tell me since when you are having this difficulty in solving?
Doctor, this is going on in the last 1 year, doctor.
All right. And can you please tell me how it started and how it has progressed over the last 1 year?
Doctor, it's slowly progressing to the worse now. I'm afraid of eating.
Mm-hmm. All right. Does it started with the solids or liquids? or both?
Both.
All right. Do you think it is more difficult to swallow solids, liquids, anything in particular?
I don't know, doctor.
Mhm. Is it difficult to initiate the swallowing, or you think the food gets struck while you are swallowing or after you have swallowed down the food?
It's going in the mouth, okay? From the mouth to the throat, it is going, then that's the problem.
Mhm. Have you experienced any pain while swallowing?
Doctor, there is no pain, but some difficulty is there. I don't know how to explain.
Mhm. Mhm. Have you noticed anything that makes it better,
Nothing like that, doctor.
like taking some water with it or anything like that?
No.
Mhm. All right. So have you experienced any coughing and choking?
I didn't experience anything particular like a coughing or choking here.
Mhm. Has the food ever came back from the nose?
No, no, doctor.
Mhm.
Carry.
All right. All right. Do you feel any sickness or feel throwing up?
No, I don't feel sick or I don't feel like throwing up, doctor.
Mhm. All right. So, have you experienced any weight changes?
Weight changes, nothing like that.
Mhm. And how is your appetite?
My appetite is not great. Because of this, I'm not feeling like eating.
All right, you're not feeling. And do you experience any high body temperatures?
No,
Any lumps and bumps in the body?
no, I don't see anything.
All right. And do you experience any weakness of any part of the body?
I feel weak general everywhere. It's not just one part of the body. I just feel weak everywhere.
Mhm. You told me that you experience some joint pains. Can you please tell me which joints do you feel pain the most?
Over the body, it's paining. All over the body, I feel weak.
Mhm. Any joint stiffness you experience? All right. And do you noted any skin thickening or tightening?
No,
Is it difficult to stand up from sitting position?
no,
Do you have any difficulty placing things in the overhead cabinets?
no, doctor. I don't do that. I'm too old to do those things.
Has anyone told you look paler than before?
Doctor, am I looking like that? You have to see and tell.
All right, all right. So may I ask you a few general questions if you don't mind?
Yeah, sure.
Have you experienced any voice changes?
No, my voice is just the same.
Any difficulty in breathing?
Yes, doctor, I do have.
You have difficulty in breathing. Is
Yes.
it on rest or when you do something on exertion?
Sometimes it occurs in rest, but sometimes if I just try to do something, if I go to the, if I go to the farm and if I try to just pluck out some weed or pluck out put some plantation or something like that, that time I'm having the difficulty in breathing.
All right. Have you experienced any dry eyes or dry mouth?
Not at all.
All right. Do you have any headaches?
No,
All right. Any chest pain?
no, not at all, doctor.
All right. Any cough or phlegm?
No,
All right. Any heartburn?
I don't have any heartburn, doctor.
Any tummy pain or discomfort?
No, I don't have any tummy pain or discomfort, doctor.
Any problem with bowel works like any hard or loose stools?
No, doctor.
All right. Any problems with waterworks, like increase or decrease in amount of waterworks?
My waterworks are just the same, I feel.
All right. Any problem adjusting to hot or cold weather?
Perfectly fine in any kind of weather, doctor.
Mhm. Do you feel dizzy when you stand up?
Dizzy when I stand up. Nothing like that, I feel, doctor.
Any skin rash?
No.
All right. May I ask you a few personal questions if you don't mind?
Yes, please.
All right. Do you smoke, Mrs. Sheila?
No, doctor.
All right. And do you drink?
No, no.
All right. And may I ask what do you do for a living?
Doctor, obviously, I just work in this field, doctor. I'm just a farmer. I just work along with my other family members.
And how are these symptoms affected your daily life?
Of course, doctor, shortness of breath, I'm not able to eat, and all these things, obviously, it's affecting my day-to-day life. Of course, yeah.
So I will try to sort it out and help you as much as possible. Do
Yes.
you drive?
No, doctor.
All right. All right. And have you traveled recently?
No, where I will travel, doctor. Already I'm having shortness of breath, even going for a short distance these days, where I can travel.
Mhm. Mhm. All right. So, Mrs. Sheila, are you married?
Of course, doctor, I'm married.
Mhm. All right. All right. So, may I examine you?
You want to examine me? Yes, doctor. You are starting your examination at 7 minutes, 12 seconds. Yes, go ahead. Tell me what you
All right. So I want to have a general look of the patient.
patient is sitting. Old lady. Tell me what you want to see. You want to do the general examination.
So I want to look at the face and the arms. At the general face, is she wasted, cactic?
Yeah, I'll show the general examination. See the lady. Okay. See the lady. See her eyes.
All right, I can appreciate anemia. Yes.
Here.
I want.
Okay.
Mhm.
See her hands. What else you want to know?
Is there any clubbing?
No clubbing. You saw the nails where there was clubbing.
So I would like to check the pulse,
Check the pulse.
and
Whatever given outside. That's right.
yes. All right, all right. So I would like to check for any proximal myopathy.
Proximal myopathy. You mean, okay, fine. You can check. There is no proximal myopathy, but she is weak.
All right, all right. So all right. So I will examine the oral cavity.
Oral cavity. Yeah.
Are there any oral ulcers, any oral thrush?
There are no oral ulcer or thrush, but you can see, the corners of the mouth, there were some healed ulcers.
All right, all right. Can you show me the face again? I So I would like to, in the oral cavity, I would like to check the position of the uvula.
Uvular position is normal, doctor. It is there in its place.
Mhm. Is there any neck swelling? I would like to check the lymph nodes.
There are no lymph nodes. There are no neck swelling.
I would like to see her soles of the feet.
Soles of the foot. Soles of the
Is
foot.
there any thickening?
No, 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 nothing is there.
All right. So, Mrs. Sheila, do you have any family history of similar problems?
Nobody in the family has any such problem, doctor. You have 1 minute left for examination.
All right. So at this point, I would like to offer auscultating the back of the chest
You can
for
ask
any fine crepitations, and
1 minute. You can.
yes, I can. I want to offer palpating and auscultating the pulmonary area.
Nothing is there. Nothing is there in that lady.
All right. So, what are your concerns, Mrs. Sheila?
Doctor, what's happening to me?
So, Mrs. Sheila, there are a number of reasons of difficulty in breathing, difficulty in solving. So, what I'm going to do is to run some tests along with some scans. Um then I will be in a better position to guide you regarding the diagnosis and further management.
Okay. Doctor, like, is it something serious, doctor? Can it be cancer or anything? Because some of my friends, like in the village, they are telling some people who just went like me, then they were diagnosed as having some cancer. Could it be cancer?
Mrs. Sheila, cancer is one of the possibility, but at this point, I cannot, until we run some tests and the investigations are out, we cannot fully confirm this, that is it cancer or not. But cancer is one of the possibility that we need to rule out.
Okay. Doctor, could it be like, so should I get admitted here or I can now go home?
So you don't need an admission at the moment. We will run some tests on outdoor basis, and then we can sit back together and guide you further.
Okay.
Do you have any other concerns?
Thank you so much. Your time's up anyways.
All right.
Can you tell me your positive physical findings in this lady?
So this patient was clearly wasted and cachectic. She had obvious pallor along with her thickenings of skins of her palm.
What? Skin thickening? Skin thickening?
Yeah, I can appreciate some thickening of skin of her palms.
Her palm is
only.
okay. Then? So what are your differential diagnoses based on this? What are you coming up to say?
My first differential, it could be Plummer-Vinson syndrome.
Okay.
Second, it could be esophageal stricture or malignancy.
Okay. Third?
And
so can you tell me, how are you going to investigate? So suppose we keep it like, she is having Patterson-Brown-Kelly syndrome. That is a name UK people want to be heard because this Plummer-Vinson syndrome is discovered by two different group of people at the same time. Nearly one set in US, other set in UK. We are writing UK exam. Okay, so Patterson-Brown-Kelly syndrome. All right. So tell me, how will
all
you
right. All right.
what you will find?
So we will run some general investigations, including the complete blood count, and especially we will be looking on the RBC indices for any hypochromic microcytic anemia. Furthermore, the specific investigations in this case will include barium solo, along with the contrast enhanced CT of the neck, chest, and abdomen.
Chest and abdomen. Okay. So how will these are the specific investigations for you? So how will you treat?
Sorry.
Doctor?
So the treatment will be patient education and counseling, a multidisciplinary team. Hello?
Yes, doctor, I can hear you. Tell me, go ahead.
Hello?
Yes, doctor, I can hear you. Go ahead.
So it will be. So management will be according to patient education and counseling, a multidisciplinary team, including gastroenterologist, radiologist, and specialist nurses, along with psychosocial support. It will be according to the diagnosis. If it is Patterson-Brown-Kelly syndrome, then we will need to treat the anemia with the oral or IV iron supplement, along with the endoscopy. We can break down the webs, and if there is any stricture, then dilatation of the structure.
Okay, doctor. Okay, I'll stop here. Your time's up. Okay. First, where is the skin thickening here, doctor? Some people are typing scleroderma. Some doctors are typing. Where you found scleroderma? Where is
This is, I think, just the rough skin. This is just rough skin.
normal skin in many old ladies? If you go in the village, their skin is like that. This is not a scleroderma. Scleroderma, you cannot easily ever the eyelid just like that. This is not scleroderma. There is only pallor. There is no scleroderma.
Yeah.
That's scleroderma skin at all. You just go to the YouTube and watch my scleroderma examination. Koilonychia, it's not so obvious also in this lady. That's just pallor is there and tongue has some pigmentation. That's it. Nothing else there. Okay. So what is the diagnosis here? What things went right? What thing? There is not much you can examine here in this particular lady, but I will tell you something. This lady, you are expected to at least examine the abdomen little because it's a case pertaining to GI system. Instead of
Yeah.
treating and checking her pulmonary area, you will be definitely expected to touch her tummy. Instead of wasting time over there in the abdomen, in the pulmonary area, auscultation, and basal crackles. I don't know why you went for a basal crackles here. What is the purpose, doctor? What is the purpose for checking basal?
So she was having some shortness breath, so that's why I wanted to do it,
Shortness of breath is due to what?
to just rule out
This shortness of breath is due to what?
anemia.
It's due to anemia.
Anemia.
At this age, a lady is having anemia. You have to check her abdomen. That's must. And
Mhm.
identifying sense, you told me that's it. But please don't tell skin thickening and all because they will straight away put unsatisfactory and they will write that you invented sign. There is no skin thickening. I hope all of you are clear. There is no skin thickening. This is not a scleroderma patient. Don't get confused when you encounter such patients, especially candidates who are going to appear for your PACES examination in India. Be careful. And doctor, did you ask about any way that she is losing blood? Did you ask about dark?
No. Sorry?
Did you ask about dark stools?
No.
Any vomiting of blood? Any bleeding through nose? Any easy bruises?
No. Mm.
None of the thing. You are expected to ask those things in this particular lady. 101% you are expected. Otherwise, you will get a borderline. You are expected to. Okay, your differential diagnosis is fine. This is Patterson-Blaum-Kelly syndrome. And with some esophageal carcinoma can be there, some stricture esophagus can be there, chalacia, whatever it is, you can tell. And there is also a condition called pharyngeal web. This is a cricoid web. That's a pharyngeal web. Anything can be there. It's fine. Then again, there are some specific symptoms pertaining to this particular lady. Second, again, clinical judgment. One very important thing, you said complete blood count. And you have to mention iron studies. Should we do or not in this patient?
Yes.
Iron studies are must than anything else. And the other thing along with iron studies, what you need to do here is OGD scopy. Is it must or not? Yes. So this
Yes.
are expected. If you don't tell, that will become here. This is fine. This is fine. This will give you an unnecessary borderline and be very, very careful. Skin thickening. I didn't put you unsatisfactory, but typically strict examiners, Scottish people and all, they put a unsatisfactory if you tell something that is not at all existing. At least this investigations you should tell specific. Then you can talk about other all investigations. Stool studies you can do. You can do every investigation, manometry, everything later. But OGD scopy and iron studies are the main investigation here. I hope all of you clear till now. That's not a scleroderma, right? I hope all people should be clear with that first. Even if you don't identify a sign, it's okay. Don't invent sign. Okay. Next thing. What about this? What are the things that we will find here? The patient will have dysphagia, obviously. The patient will have shortness of breath. Obviously, yes. The patient will have glossitis. Yes. The patient will have angular cheilitis. Yes. And there is a specific symptom for this patients that is called glossodynia. You know what is meant by glossodynia? Tongue pain. The patient will typically tell, there is a pain in my tongue, doctor. Pain in my tongue. Tongue is paining. Tongue is hurting. That is called glossodynia. That is very, 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 very specific for us. Okay, so what do you do? Basically, you're gonna correct the iron deficiency anemia. That will solve most of the thing. And esophageal bogey dilatation we do. Just put the bogey and dilate the esophagus and with the pharyngeal web, you have to dilate. That's a surgical procedure, but even now our medical geniuses are doing that. No, without anything, our medical gastro team also doing the same thing. Okay. So any doubts in this case before we go to communication, then we will going to go for approach for dysphagia. Everything about dysphagia in and out we are going to learn today. That is the purpose of this long webinar. Any doubts? No. Dr. Minam Akbar, are you there? Say hi to me. The differential diagnoses are straightforward: Patterson-Brown-Kelly syndrome, stricture, malignancy, achalasia. That's it. Yes, Dr. Meena Magpur. I'll just unmute you first. Dr. Meena, you are unmuted. Are you there? Hello?
Yes, sir.
Yes. This is your case. A lot of people told that the communication scenarios, whatever you're posting, nothing is seen. Letters are small. Now I made a big letter. This gentleman actually had the condition. He is the one who just brought the cartoon. This, what is that? SpongeBob. Yeah. Jason Geller. Sadly, in a young age, he was diagnosed with ALS. Doctor, all of them can join now. 3 people more can join. I'm sorry about the capacity. It's just like kind of overflowing. Like they will. I'm allowing everyone to join. There is nothing in my control. Like everyone can join. There is no unmute or mute. 3 slots are open now. It is open because after this communication scenario, only we have important discussion going on. People are coming and sitting for the clinical consultation and leaving. The most important consultation, most important scenario will come after this only. We are going to see how to approach dysphagia, all the theories of dysphagia, theory related to dysphagia, what are all the cases that came in related to dysphagia and cases. So weekly, 2 topics we are going to discuss completely for free. All can enjoy. Come and join us. I'll just give you 4 more minutes. 1 minute's over. 4 more minutes. We will start. Hello, Dr. Meenam, are you ready? Hello, Dr. Meenam, are you ready? Are you not? Are you unmuted? Muted again or what? Where is she? Dr. Meenam, are you there? Others can hear me? Yes, where is she? Dr. Meenam, she is disconnected or anything. Somebody else has to chip in. Dr. Meenam, Dr. Meenam, are you there? Dr. Meenam, I don't know if she's disconnected or anything. Is she there? Yes, there she is. I found her. Dr. Meenam.
Yes, sir, I'm here.
Yeah. Okay. Go ahead, doctor. Go ahead. Start, please.
Hello,
Hello.
I'm Dr. Akbar. I'm one of the senior registrars in the brain clinic today. May I confirm that you are Mr. Jason Geller, 55 years old?
Yes, doctor. I'm Jason Giller. I'm 55-year-old.
How may I address you?
You can call me Jason.
Mr. Jason, I'm here to discuss regarding your health condition. Do you want anyone else to be in this meeting today?
I don't have anyone basically. You can tell me.
Okay, so to be on the same page, I would like to know that how far do you know about your condition and what are your expectations from today's meeting?
Doctor, I just got some lung bug, and I just also know that aware of that, like some of the muscles of my body is not functioning well. It's kind of slow, or rather, it's kind of weak. I don't know,
Hmm.
and this is really terrible for me to digest. At this young age, all these things are happening, and I don't know, doctor. I'm not feeling good about this. I'm really sick and tired of my life.
Mr. Jason, I'm sorry for what you are going through right now, and I'm here to address your concerns as well. May I know that do you have any idea that what are you going through, or anyone has discussed about any condition with you? Do you have any idea about this?
No, I told you, doctor. I am aware that my muscles are not functioning, especially all the muscles in my body. I'm feeling weak, the muscles of my foot pipe. Nothing is working out well. And I just got this lung bug adding to that, and all the medicines through my blood channel. It's just really tiring and heartbreaking, doctor. Really heartbreaking.
I can understand, Mr. Jason, and you have been diagnosed with a condition called as amyotrophic lateral sclerosis.
That is,
Do you want me to explain you more about this?
yeah, yeah, tell me, doctor.
Okay, so Mr. Jason, it's a kind of a progressive brain condition. In this condition, brain cells in the nerves started to get die timely, and it affects the brain and the main nerve cable. With this progression death of the brain cells, the body loses the muscle control. There will be muscle weakness, and in severe form, there will be swallowing difficulties, speech difficulties, and breathing difficulties as well. Are you understanding me?
Oh, God. Yeah, that I'm aware of, doctor. Yeah.
Hmm. So, Mr. Jason, as you have mentioned me that you had a severe bug infection in your chest, and we have a management plan for you so that we can discuss more about the other options that how we can manage the condition as well and the other feeding options as well. How's that sounds to you?
Feeding options. Okay. Anything there, doctor? Anything you can give me that my swallowing can improve?
So, Mr. Jason, we have team of doctors with us. There is a brain doctor as well, and we have a speech and swallowing assessment team as well. They can assess you as well, and there are some form of swallowing therapies and exercise can be there as well. But as I mentioned you that this is a progressive condition, and with time your condition will gonna progress, so you will be requiring some form of feeding tubes, and that will be helpful for you as well. How's that sounds to you?
Yeah, doctor, that's okay. It's fine.
Can I discuss more about it?
Yeah.
So we have some options available in form of percutaneous endoscopic gastrostomy tube, the PAC tube. Have you ever heard about this?
Doctor, this term, what you are speaking itself is Greek and Latin to me, doctor. What is percutaneous? What is gastro? I know only tube.
Okay. I can explain you in more simple words that it's a simple feeding tube, and I can draw it for you. Okay. So it's a small tube, and usually what we'll do that we attach this tube to the skin of your tummy, to the inner lining of your gut. With a small procedure, you can say it's easily get attached. This tube seems to be in a very small size. It has a very large bore as well, and it's easy to get handled as well. And the food can easily be given to you through this tube as well. Um, During this procedure, while passing this tube, you can have mild numbness and pain can be there as well, but that will be only for the time being as well. And after passing the tube, it's like we will gonna teach you how to manage this tube. We have some nurses as well that they can guide you and teach you that how you can clean it, how can you have the food through this as well, and what kind of a soft food you can have through this tube as well. So are you with me?
Doctor, yes, I am with you. You are telling it very easily by drawing in a paper, doctor, but listening to this is just like scaring me and chilling my bones.
Okay, may I know why?
Of course, doctor, seeing this tube, you are telling you are going to put it through here, there. My God, already I am suffering enough, doctor.
Mr. Jason, I can understand your concern, and it's not easy to go through a condition like this. But this is one of the good options we have for the patients who are going through this brain condition. I can understand that this seems a little difficult to handle such tubes, but this is a very small tube. You can easily hide it under your clothes as well. And by teaching you how to manage it, how to clean it, you can easily manage it. After passing this tube, there are chances that, as I mentioned, that this disease affects the swallowing capacities of a person. The chances of episodic and on and off bug infection will be less likely. So the chances of infections will be reduced as well. You can manage it well as well. And don't worry, we have nurses with us. They can teach you, guide you. And if there is anyone in your family, we can guide them as well, how to carry them and how to cope up with the tube as well. How's that sounds to you now?
Oh, doctor, that's absolutely sounds very overwhelming for me, doctor. But I'll definitely think about it, doctor. Definitely, I will think about it.
Okay. And may I know a few more questions from you, Mr. Jason?
Yes,
May I know that what you do for a living?
doctor, I work as a producer, doctor. I just produce these cartoons and stuff, like the famous SpongeBob. It was produced by me.
Okay, good to know that. And may I know that how are the symptoms affecting your daily life with
My
this
daily
overall condition?
gone. I stopped producing, I stopped everything. I'm just like living alone now. Like, I'm not doing any of these things, doctor. 8 minutes over, doctor.
Oh, So is there anyone else at your home that to support you, and is there anyone?
Well, doctor, in my home right now, I have some caregivers, doctor. I have some caregivers and some nurses who are there to just support me, and I have a maid at home, and I don't have anyone else beyond that. But these are the people I'm just living with.
Okay, so I can understand your concern, and we can provide you some psychosocial support as well, some support group therapies we can offer you as well, so that it will be quite overwhelming for you if you offer you. How's that sounds to you?
Oh, okay, doctor. Like some support group. I was also looking for some support group. That's great, doctor. I will be really happy to have some support group to, actually help me out. Yeah.
Okay, all right. And may I know that do you smoke?
Yes, doctor. I do smoke, not often, but sometimes, like when I'm just like really stressed, when these things are building up in my head.
Hmm. Hmm. So, Mr. Jason, I would like to advise you that smoking in any form, it's not good for your health in any way, and you should quit or start thinking about quitting smoking. How's that sounds to you?
Okay, quitting smoking. I will definitely try, doctor.
Yeah, and may I know that do you drive?
Yes, doctor. I do drive. I do just drive. Yeah, it's fine. I can drive. Do
Okay,
vehicle. Yeah.
okay. So, Mr. Jason, I just want to tell you that as this condition affects your muscle strength and muscle weakness as well, sometimes you can have some difficulty in breathing. If you feel any form of weakness during this time period, I would advise you to hold on your driving till
Yes,
your condition assessed by driving and
drives on
vehicle
its own.
authority. Okay, okay, sir.
Tesla, it drives on its own, and your time is up.
Okay, sir.
Dr. Minam, what you have done right, what you have done wrong. You are listening to our classes, you are a part of us. Really happy you have the basic knowledge and everything. But where you just digged your own grave, do you know, in this scenario? I'll be very honest with you. Not a single concern has been asked. That entire 10 minutes is over. Not a single concern has been asked. One recent feedback I saw, he is a good candidate, really good guy. He can identify every sign you give. His examination skills are good. His clinical judgment is superb. MD, DNB medicine with 9+ years of teaching experience of medicine in India. Seen almost all the cases. Just he failed to address the concern. And one area, another area, he did the mistake, he is blown out. So here you did not answer, ask also any concern. I gave you a warning that only now 2 minutes left. This will straight away go unsatisfactory. This can be very, very, very bad for the exam. Very, very bad and dangerous for the exam. The patient welfare you had maintained. Your communication skills, I don't deny it is good. Again, coming to clinical judgment. Here, extremely important thing, advanced directive and lasting power of attorney. Not asked. You should ask who is next. Any decision has been made. Who is going to take this decision? If anything goes wrong, already MND with aspiration pneumonia, anything can go wrong in this gentleman. And the next thing is, what is the task at hand? The task at hand is not explaining motor neuron disease or ALS. If you carefully listen to your recording again, this recording is free, it is going to be uploaded in YouTube. In the entire 4 minutes, what you are doing is continuously you are beating around the bush about ALS. He already told in the very first minute, I know what is ALS. I have muscle weakness. I am aware of that. Then why you would go around telling about ALS? And the only thing that was explained is PEG. I'm sorry, I got just like random up going on. This is the same scenario I got during my second exam, where again I failed during my second PACES attempt. Okay, so what is the task at hand here? Task at hand is to go ahead and talk about all sort of, and all kind of feeding options. And what feeding options you were talking about is talking about PEG. Did anywhere it's mentioned you just explain about PEG? No. That will again create trouble here. So what you have to do? Talk about IWeb. You introduced, you verify, agenda, set the permission, check the knowledge. Fine. Food, instead of going through a foot pipe, is going through a windpipe. That is aspiration. Difficulty to swallowing is due to weakness, you told. Some social history thing. Then, among all this thing, you have to explain all these three different feeding procedures. Three options are available. They will check your clinical judgment and clinical knowledge there. Okay, I'll just quickly go through. What are the procedures here? NG tube, PEG, jejunostomy. You need not sit and talk about every procedure in long time. If they mention only PEG, detail. If they mention feeding options, then you have to talk about all the options. The nutritional support, salty, mood, concerns, pamphlet, these and all you can tell at last. So what are the things you need to tell? What are the things you all need to know about these three things? This is a beautiful table. I just happened to get it. So NG tube in general, it is a simple, commonly used. There is no need for any anesthesia. PEG, it avoids mouth, nose, all the things which you have told. Requires endoscopy, but better tolerated. Jejunostomy, same thing. Complications, everything that requires like infection, bleeding, pain, all these things will be there. And, NG tube cannot be given for long term, but this too can be given for long term. PEG is for long term. Jejunostomy is middle to long term. Okay, all these things can be given food, continuous bolus with fluid. And feeding jejunostomy, you have to give more of a bland and digested food. What they call, they use a term for that, I forgot. Feeding complications, what can occur? Again, absorption can be there. Again, aspiration can occur. Regurgitation can occur in both. Okay. So all these things you need to explain clearly. TPN means total parenteral nutrition. Okay, this is about nasogastric tube. If you want to explain, if they ask you to explain only about nasogastric tube, these are the things you need to explain. You will need to ask. Sit upright, a narrow feeding tube will be passed. This everyone knows. pH is tested, tube is then secured. Typically, you have to test with the X-ray, not with the thing which we are doing in India, we have done in India, that is just giving a syringe, poof, and then using a stethoscope. That's not how it is done. What are the questions? Can I still eat or drink? Speech and language therapist will help. How long the feed is attached? I may ask you. It depends. Will I be able to move around? Yes. Will I be able to take a bath or shower? Yes. These are the questions actually asked by patients. Okay. So the risks I had already told you. This is a PEG tube. This is what you are supposed to draw. There's a clamp, there's a tube, there's a fixator, there's a bumper. This is the PEG end. Okay. So this is what we need to give for the patient. Suppose they are asking. I'm just talking in general, not just about for patients. Okay. How it is done, you are correctly told. Tube and the camera is passed down to the stomach. Shining light is there. Then a cut is made through the skin and the tube is attached and inserted. This is the simple picture. You don't need to draw about layers of skin or anything. Just this thing, simply you draw, that's more than enough. This is your tummy, this is your foot pipe, this is the scope, light bogey is there. Outside, we are going to attach. You don't need to mention about bumper and all those things. Okay, so this is the scenario. Now we are going to go to the dysphagia proper. Couple of things we are going to learn. One, guidelines. This week, we are going to learn about Barrett's esophagus. Every week we are going to have, yes, doctor, whoever has doubt, please type. Progressive aspiration, regurgitation, can we use this word? No, it's not. It's better not to use. But aspiration, instead of that, the word I said, food going through your windpipe instead of your, okay. So all your doubts kindly ask, because I'm not unmuting anyone at this point of time. So you can ask your doubts in the chat. Everybody's doubt I will answer. Okay. So this is Barrett's esophagus guidelines from British Society of Gastroenterology. So what they are telling, endoscopic evidence of columnar lined esophagus. That's a Prague criteria. If it is there, what they're telling is to do quadrantic esophageal biopsy every 2 centimeter. Every 2 centimeter, you take a biopsy. Then you find two things, a squamous epithelium or a glandular metaplasia. If the squamous epithelium, just you review, because that's a normal thing for esophagus. However, if you are finding a glandular metaplasia, then it is a Barrett's esophagus. Then clinical review you have to do. If it is a metaplasia, repeat, then discharge. Again, you see if it is a metaplasia, repeat and discharge. If it is not a metaplasia, if there is a dysplastic change, you do the surgery. This is the simplified guidelines for Barrett's esophagus. Okay. Simplified guidelines for Barrett's esophagus. So how are you going to approach dysphagia in case of PACEs or in case of your day-to-day clinical practice? How to approach? This is the most important point I want everyone to know. There are some fancy terms in dysphagia recently. If you go to the Harrison's recent edition, it will be there. Transverse dysphagia is nothing other than nasal regurgitation, like pulmonary aspiration during swallowing, which has happened in this case. There is something called phagophobia. They call that is a fear of swallowing. So some terms in dysphagia you need to know. Dysphagia means difficulty in swallowing. There is something called aphagia. That means inability to swallow. The patient will not be able to swallow at all. Then odynophagia is painful swallowing. There is something called globus pharyngeus or globus hystericus. That is foreign body sensation localized in the neck. So this is the overall simplified approach of dysphagia. This is taken from Yamada textbook of gastroenterology. This is for DM gastro, CCT gastro people they use. A simple thing, history and physical examination. If there is a complete esophageal obstruction, that is what they call aphasia, not at all able to swallow, urgent EGD scoping. If there is a difficulty initiating the swallowing, like, as soon as the patient keeps the food, the patient is starting coughing, aspiration, nasal regurgitation, then oropharyngeal dysphagia is the thing. Then you go for a video fluoroscopic swallowing study. If the food is sticking in the esophagus, then it's called esophageal dysphagia. Esophageal dysphagia, then do biopsy. If there is a diagnosis, treat. If there is no diagnosis from biopsy, they are asking to go for a esophageal manometry. If there is no diagnosis with esophageal manometry, go for barium swab. So what are the causes of oropharyngeal dysphagia? Huge list is there. You can take a screenshot if you want. Okay. Please, no need to worry about the slides that has passed. This video will be uploaded for free. You can watch the video anytime. Okay. This video is available anytime. Somebody asked a doubt why you need to discuss about that. Question is, what are the options available? So they expected you to tell what are the options available. Just in a quick succession, 2 to 3 minutes. Then whatever he wants to choose, he can choose. If the question says you discuss about PEG, you discuss about PEG. That's it. All right. That's what the feedback also candidates got. Because some people discussed about PEG and came, some people discussed about NG tube and came, some people discussed about GG tube, GJ. Discuss about every options that is available. Stress on PEG, leave. Then next is esophageal dysphagia. Esophageal dysphagia, these are the causes from achalasia to scleroderma to spastic motor disorder, esophagic junction outflow obstruction, intrinsic lesions. All these are causes of esophageal dysphagia. So these are the causes of odynophagia. Okay, these are the causes of odynophagia. There are some drugs that can cause odynophagia, like doxycycline, NSAIDs, potassium supplements, bisphosphonates, all these drugs. So how do you approach a dysphagia? First thing, ask how long. Is it for liquids, solids, or both? Is there a food that is stuck in your mouth? Do you cough, choke, nasal regurgitation? Is there a lump in your throat? Is there a water brash? Is there a bad breath? Is there a weight changes? Are there fever? Are there night sweats? Skin tightening, color change, pain in fingers, difficulty opening mouth, pain during swallowing, frothy urine, all these things, then plus systems review you have to do. These are the basic approach of dysphagia. These are the basic questions you are expected to tell. So what are the pointers? A rapidly progressive dysphagia could be malignancy. If dysphagia is more for solid than liquid, it can be malignant obstruction. Coughing, choking, nasal regurgitation, like we saw already, that Yamada's table, that is oropharyngeal dysphagia. If the dysphagia is for liquids and not solids, then motility disorder. Remember, these are very important points. So what are the differential diagnoses? These all these things we have already seen. Drugs, these are the drugs. Inflammatory, these are the causes. Structural, these are the causes. Neoplastic, these are the causes. Neurological, achalasia, cardia, bulbar, pseudobulbar palsy, MND, MD, Parkinson's, MSA, everything. So coming to some important conditions and the thing which you need to know about that. Achalasia cardia, there's a strong risk factor. There is something called Algrove syndrome. You all know, I believe, achalasia, alacrimia, and adrenal insufficiency. So what you're going to do, you're going to do UG endoscopy. Mucosa will be obstructed by the retained saliva. And esophagus may be dilated and tortuous. Barium swallow typically show loss of peristalsis, delayed emptying, and dilated esophagus, which tapering, that is called a bird beaking or rat tailing appearance. High resolution manometry will show incomplete relaxation of LES. Chest X-ray, what it will show, once an examiner asks, what you'll find in a chest X-ray here, you're going to find absent gastric bubble, dilated esophagus with air fluid level. All right. So management is going to be your nitrate, pneumatic dilatation, laparoscopic cardiomyotomy for poor surgical candidates if they ask Botox. What are the complications? It can lead to aspiration pneumonia, GERD, and esophageal carcinoma. Next, Barrett's esophagus. These questions can be asked. You cannot tell a patient having Barrett's or anything unless you do UGD and biopsy. So reflex, increasing age, white ethnicity, and male sex are at high risk. We have already told how to approach that. Low grade radiofrequency ablation, endoscopic resection, surveillance, and PPI. High grade esophagectomy. Just remember these two lines, it's more than enough. Then there's another condition called eosinophilic esophagitis. Then you can do for this patients OGD-scopy, biopsy, FBC with esophageal string test or cytosponge test they will do. Eosinophilia, anything is there, it responds to steroids. Plus PPI plus endoscopic esophageal dilatation is what you have to do here. Coming to the last part, we are going to have some quiz. All of you brace up and tell me what is the diagnosis in the chat box. I'm just opening the chat box and I'm keeping over here. We are going to see some of the conditions which is needed for the entire MRCP and medicine exam. Quiz starts now. Can you tell me what is the diagnosis seeing this image? Excellent. Yes. So, all right. So here is a patient, okay, 65-year-old Caucasian obese female who presented with heartburn and indigestion. Episodes of nausea about 3 years. Initially, she would get occasional episode of spasmodic pain in the upper epigastrium. With nausea lasted for few seconds and many medications were tried, nothing improved. What is this? Yes. Now this case, anybody know what is the answer? A 54-year-old male with the typical medical history of hypertension and GERD is presenting with dysphagia. It is intermittent and only to solids, most commonly when eating beef or chicken. He estimates the symptom occur 1 time per month and has remained stable over the last 6 months. Correct answer I want. Anybody? No, that's not pyloric stenosis. Pylorus is not there. This is called Skatsky ring. Who told correct answer? Somebody told exactly, Dr. JK. Yes, this is Skatsky ring. Excellent. This is a Skatsky ring. Perfect. All right. Now this one. 65-year-old male patient presented to the clinic. These are the type of cases you will get. Chief complaint of difficulty swallowing, has been experiencing problem for the last 2 years. Symptoms progressively worsened. Reported experiencing a choking sensation, regurgitation of undigested food liquid into the mouth after eating. This is more than enough to tell you the diagnosis. See here, what is this? Excellent. This is a Zenker's diverticulum, not MND. What is that PP, doctor? No, this is not a ring. This is pharyngeal pouch, Zenker's diverticulum. Okay? This is a Zenker's diverticulum. See this case. 52-year-old. Okay, this case you leave it. This case you see here. Just see the case and tell me what is it. This is the case we have discussed just now. This is a case we have discussed just now. Yes. It's a post-cricoid web. Same case which we have discussed just now. Okay? Rat tail. No. That's a post-cricoid web. That's not rat tailing. See here. Can anyone tell? This is a 35-year-old male, weight loss, genital lesions. See this. Can you tell me what is this? 35-year-old male, weight loss, genital lesions, casual sexual partners. Excellent. Yes, candidal esophagitis. This is one of the telltale sign of HIV. If you find this, then the patient is having HIV. This is one of the HIV AIDS defining lesions. This one, and you know your the other thing, all these things. Okay. All right. Look at this patient. This patient has dysphagia. See the sign and tell me what is the diagnosis. These are the cases that came. Just watch the jaw jerk. Okay. Just a minute. Wait a minute. Just watch the jaw jerk. Just give me a few seconds. Sir will demonstrate jaw jerk. Okay. Watch the jaw jerk and tell me carefully what is the cause of dysphagia in this patient. See here. Excellent. This is a pseudobulbar palsy. That is exaggerated jaw jerk. Next patient. This patient has a dysphagia. These are the cases that came. Look at the patient. First, tell me the signs that you are seeing in the screen. What are the signs you are seeing in the screen? First, you tell me the signs. Then you tell me why he has dysphagia, that is secondary. What is the sign you are seeing in the screen? Excellent. This is a bulbar palsy. Tongue wasting and tongue fasciculation is there. This is another case we have got. See the picture and tell me this patient has dysphagia. What is the cause? There is salivary gland swelling. What is this? This is anterior dental caries. Anterior dental caries is typical of Sjogren syndrome, and salivary gland swelling is again typical of Sjogren syndrome. And this particular patient having a dysphagia, it's due to Sjogren syndrome due to trauma. This patient has dysphagia. Anybody? These are Pace's case. This is salt and pepper rash of systemic sclerosis. No. Who said myasthenia gravis? No, this is not SLE. This is not dermatomyositis. This is salt and pepper rash of systemic sclerosis. Now, this patient has a dysphagia. This is one of my patient. See here. What is the diagnosis? Absolutely, yes. This is myotonic dystrophy. All right. Fine. The last case, this patient has a dysphagia. What is the diagnosis? Look at the patient carefully and tell me what is the diagnosis. This patient has a dysphagia. This case has beautiful signs, like everything is there. That's not systemic sclerosis. No, this is not systemic sclerosis. See the eyes. See the eyes. Around the eyes, there is a rash. There was some knuckle rashes there. Papules are there in the knuckles. Just wait. I'll just make him sit. The problem is here, I had to hold the camera in one hand and I had to take video. Not now. This is the time I was just practicing paces. During the time I took these videos. See here. See the neck. That's a shawl sign. This is a classical case of dermatomyositis with dysphagia. These are the cases we encountered, and one case we all know, that is myasthenia gravis, presented with dysphagia due to oropharyngeal weakness. Because myasthenia, again, you will be demonstrating fatigability, ocular, bulbar, and proximal muscle fatigability. So oropharyngeal weakness in myasthenia gravis came as a dysphagia. One more case that came as a dysphagia is a esophageal cancer, a patient with a long history of smoking and alcohol. That's all about dysphagia. We have seen almost everything, all the cases, approach, what to do, what not to do, communication scenario associated with dysphagia. All right. So next week, we will come again with another 2 topics like this. We will discuss. It's absolutely free. I'll upload in the YouTube some other time later. Okay. Thank you, everyone. Thank you so much for watching. And thank you so much for coming up. And please do leave your valuable feedback in whichever group you are coming from. All right. Thank you so much. Yes, vasculitis, you want a class. I will try my very best, doctor. Okay, I'll try my very best. The problem is I don't have a mobile now. It's gone. Like I need to just using somebody else's mobile. I'll just get it fixed. And once I get it fixed, I'll definitely come with a vasculitis. Maybe next week I'll try on vasculitis. Definitely. Thank you for your suggestion. I will do it. Okay. You're most welcome, doctors. Please leave your valuable feedback in the groups you guys have come from, MRCP Institute or Astrocyte or just Paces Pro group, whichever group it is. All right. We love you all. Thank you so much from Pacesdiaries team and every one of us. You guys are more than welcome to learn with us. Okay, we are there to help you out. You can try and approach us in our groups. We are more than happy to help you learn through the paces. We teach clinical medicine, not just some paces and stuff. Okay, I will definitely upload and I will put the link. It will take some time. It will take 2 to 3 days. I will upload. Okay. It will take 2 to 3 days. I will upload. I will definitely increase the capacity. I'm really sorry that beyond 100 people couldn't come because there's some verification that has not been done. That has to be done. Okay. I will do it. Thank you so much, everyone. Great day. Have a great day ahead. And we are here to help you and support you in your learning. Best wishes. Please do leave your feedback. Thank you.